Hey guys, Dr. Marshall Lemoyne here with PhysioU. I'm here with Cameron and Chris, two third-year DPT students, and today we're going to be talking about surgery. Right? Often that's the question patients come in and they always ask the therapist instead of the surgeon sometimes, like, oh, should I get surgery? Should I get surgery? And so we want to be able to be well-informed and answer it as best as we can. And yeah, let's start with some questions.
So just being in the clinic, a patient comes in, they've had their MRI, has whatever pathology, and they ask you that question, should I get surgery? How would you best answer that question in our position?
I think, again, as the title says, well, it depends, right? So the pathology, depending on what that pathology is, there are some that research shows are very, very common in asymptomatic people. So if you are well-versed in that, meaning you understand that, hey, if someone with lumbar abnormalities on an MRI, right? So if we think about someone with disc bulges, right? Most people have disc bulges over the age of 50, right? I think high numbers over 60, 70%. Facet degeneration, right? You think about an 80-year-old, 99% of people over 80 have facet degeneration. So it's normal, right? We tell people that's like getting gray hair or wrinkles on your skin. It's just, unfortunately, part of aging doesn't have to equal pain. So, but the nice thing is they have studies now that have kind of taken off from just the low back to looking at shoulder, looking at meniscus tears, and over 50% of people have meniscus tears that are asymptomatic, don't even know about it, and they do totally fine. So if you know that information, you can use that with your patient and say, hey, just because you have that on your image doesn't mean you have to have pain, right? So we can work on all the other things that take stress off that area to normalize it. That being said, if somebody comes in and they have that thing and their story fits, hey, it's traumatic, I can't do all of these things because of it. It's not like they're living with a 3 out of 10 pain that they just woke up with. It's, oh no, my knee was hit, it's catching and locking, right? And they're 24, and they're thinking, should I get a meniscus surgery? That's a very different than the 55-year-old lady that just has pain in her knee, that doesn't really remember anything happening, had an MRI that shows a meniscus tear, right? It's like, oh, same thing on image. One, I would probably say, yes, you should go get surgery. The other one, I'd say, hey, let's see if we can handle this conservatively, because studies show a lot of people have that exact same image and are totally fine.
So in terms of getting a little bit diagnostic specific, I had a patient, she had a full thickness rotator cuff tear, and really wanted to do conservative treatment. She kept saying she didn't want to go under the knife. So what is your experience with that?
Yeah, I think based on the pathology, so full rotator cuff tear, again, there's studies out there that talk about conservative care being helpful under certain circumstances, as well as surgery probably being more helpful under certain circumstances. So the first thing I'd be like, how old is that patient?
She was in her 50s.
50s, okay, so she's kind of right on
She was diabetic.
Okay, so she's right on the cuff, because people that are over, I think it was 55 and over, that have a degenerative rotator cuff tear, no trauma, over 55, right, and have comorbidities, are people that didn't have the best successful outcomes after rotator cuff tear. So I would try conservative first, versus the younger people that have trauma. They know exactly when it tore and they're younger, and they don't have any comorbidities. Those people do better, right, with surgery. So I think understanding the full picture, kind of like that meniscus patient we talked about, is helpful. So if she says, hey, I don't want to go underneath it, she's over 55, was there a trauma?
No trauma.
All right. So she's someone that say, hey, the studies show that actually 2 years after, people that had surgery and people that did conservative care, you guys are pretty equal. So if that's the case, let's definitely work on conservative care. Now, making sure we kind of advocate for the patient. If you're seeing her 4, 5, 6 visits and nothing's changing, and she is pretty limited, meaning she can't raise her arm, right? And she's not making any changes after 3, 4 weeks, like maybe it's time to have a conversation about that again. Versus, let's say she can raise her arm up and it just hurts. So she has the elevation and it hurts. Hey, let's continue to work on getting stronger. Let's continue to work on, there's something there that we can work with to improve the control. Versus she physically can't do it and it didn't change, right? So good questions. I think looking at the evidence is the best way to kind of answer that more confidently to your patient. Again, we don't want to ever be the person that says, don't have surgery or do have surgery, right? That's kind of the patient and the surgeon. And we don't want the patient going back to the surgeon and then saying, hey, right, the therapist told me not to have surgery, right? Because if I was a patient and someone's telling me don't have surgery and the other one's telling me do have surgery, that's just going to make it more fearful for me. So our job is to say, hey, based on what you present with, there's an opportunity that you may get better doing conservative care. That's very different than don't have surgery, right? Maybe kind of spin it. Yeah, but that's a good question. I would say some of the other, so besides understanding imaging abnormalities as being normal, right? It's normal to have abnormalities in your image. Understanding what the outcomes are. Hey, the people that did well in surgery, they had good outcomes. What did they have in common? Oh, their age. Oh, it was traumatic. Versus people that didn't do well after surgery, what did they have in common? Because then we can then use that to kind of help maybe influence and educate our patients more. The second thing is, remember, we are there to help the patient. So if they've decided to have surgery and they've made their mind up to have surgery, right, we probably shouldn't be the one that put those thoughts in their head to not have surgery. It's like, hey, let's get you as strong as possible, because the stronger you are going into surgery, the stronger you are going to come out, right? It's, hey, when you go into surgery, it's going to be very painful afterwards. Don't expect the surgery to make your pain go away. You just had a really big surgery. So expect it to still hurt and be okay with that because you had a surgery. So we still want to educate them and kind of show that we're on their side and we accept them. So that way they go in with a level open-minded head saying, hey, yeah, I'm okay with this decision. Last we want them to be like, oh, I shouldn't have had surgery. I should have listened to you. That doesn't help anybody, right? That doesn't help anything. And then lastly, talking about surgeries, the people that come out after surgery and they still have a lot of pain, hopefully someone before surgery told them pain is normal. You had a big surgery, right? Pain is normal. So that's hopefully kind of settled. They're not like, I've had total knee patients that are like in shock at 2 weeks after surgery why their knee still hurts. And it's like, I had surgery to fix it. And it's like, well, you had a very big surgery. I'm sorry you weren't told this ahead of time, but that is completely normal. And it's probably going to hurt for another couple months. And then from there, we can then spin it to, surgery, all it does is change that structure. Surgery does not make you stronger. Surgery does not make you have better flexibility or range. Surgery does not give you better balance. Surgery definitely doesn't make your nervous system less sensitive, right? Surgery does not necessarily help pain. It changes structure. All this work we have to do afterwards is to help you get better function, have better pain, and so you still have to do a lot of work. And so hopefully patients can buy into that and understand that, and then those people, I think, tend to have better outcomes, at least for me clinically, if they understand the big picture versus them trying to take it day by day and their knee still hurts, right? So any other questions? I know it's kind of a weird topic about surgery because you could take it to knee, back stuff.
Oh, that was perfect.
Sorry, okay. One thing did just pop up, because lumbar surgeries are one of the most common ones, right? Surgery for low back pain, just specific low back pain only, right? The outcomes are not very good, right? So they have these 5-year studies, these 10-year studies that it's conservative care versus rehab, or conservative care versus surgery. Conservative care is actually better at years following if it's just for low back pain. The people that do really well for low back surgery are the people that have neurological symptoms down their leg. So they have myotome or reflex issues, and they have an imaging to match that clinical presentation. Those are the people that have good outcomes after surgery, better than conservative care. And then what else? Who else do you think would be someone who would benefit from surgery?
Someone that's younger.
Yeah, so younger, we talked about age. Think about red flags. I think about cauda right? All the research says if they can have surgery within 48 hours, right, they are way likely to get back all of their function, right, that they might potentially lose if they wait after 48 hours. So there are certain people where we push surgery right away. It's like, hey, any bowel or bladder issues, stuff like that, whoop, go to urgent care, right? So realize we may be biased towards non-surgery because we are therapists, right? We work in the rehab world, but make sure we're also our patient's best advocate for safety. Cool. Hope you guys kind of learned something from that. Again, thanks for watching the teaching table where we talked a little bit about surgeries. Take a look at our social media stuff, Facebook, Instagram, Twitter. Give us a like, thumbs up, drop a line. Also, feel free to stop by PhysioU.com and take a look at Knowledge Central, where we have all of our mentoring minutes and our teaching table videos. We'll see you guys next time. Take care.